Good morning and welcome to our monthly webcast. I'm Samir Mehta, your moderator. This is case number 198. I believe we have possibly, for the last session of the year, I think we have the hardest case of the year. I hope you will all learn many lessons. It's pathology we are seeing much more often, calcified nodule. And we have a case where I think the calcified nodule is involving the ostium of the LAD, but it may be protruding also in the distal left main. A highly complex case. You'll watch the need and the benefits of imaging, possibly the use of rotablator. I have not reviewed either the plans with Dr. Kinney and Dr. Sharma, and like all of you, I hope to learn a lot in this case. So join me here, Samin, Anu, good morning, and congratulations on your recent valve symposium.
Don't talk too much.
Yep, good morning to Samir and of course our viewers of CCC Live.
Real trio?
Yeah, get a real trio. Yeah, so this is the case, as you said, we are getting more and more patients with structural heart disease, and particularly they're developing, give a little medicine, yeah, okay. Particularly coming with the CAD, most of them, because the studies are showing that you do it post, not need to do it pre or at the same time, but those are the trials done outside America, but we usually do it post. Very rarely the acute coronary syndrome, we do it early, lil nitro, always give lil nitro. Yeah, so this is the case which actually had the PCI, the TAVR done, had some disease, and now of course little more. So let's, with that note and knowing that this is case number 198, once we get to a 200, we'll have a separate big session, and Anu taking a picture, we just want her to show. Let's show the angiogram please yet. Don't go yet, presentation, yeah. Good, look at this, let it play. Wow, look at the calcific nodule. Looks like at both when this case was done a few years ago, there was a moderate disease of the left main. But now it has become quite significant. You can see little shadows. Both, I think calcific nodule is the disease, as Samir just mentioned, more and more recognized. Until few years ago, we are talking about maybe 5%. Now, almost 25 to 40% of cases of the calcific lesions, there is a calcific nodule. So I think this could be just the distal left main and ostial LAD calcific nodule. And Anu and Kiski, our team is ready to really identify where it is and what it is based on the intravascular imaging. Of course, you can always do the OCT also. OCT, biggest advantage OCT is it can quantify the nodule thickness. Look at this. This is tremendous work. Now, and then we have the nodule shock trial ongoing to answer this question. And we have to tell anything about this feature, case feature point of view. RCA is okay in this case, yeah.
No, I think eccentric lesion, I know the definition of nodule is coming. If we go back, even look at that circ.
Yeah.
Significant disease in the ostial circ, which also could be a nodule there. But let's, what I'll do is, we'll wire LAD, while circumflex and image both. Yeah. Right? Kiski, is that the way you want it?
Yeah, sounds great.
Yeah, no, I'll go with the rota wire to the LED.
Okay, rota wire to the LED, good. Yeah. Okay, meanwhile, we can start our presentation.
Several questions have come here, mainly talking that if you did not have the SAPIEN valve there, would Impella have been used?
Yeah, I mean, this patient has a normal ejection fraction. And we also always know that if it's the extensive work you need to do, then you should put two circulatory support device. In this case, I will try to avoid, let's say without even the structural valve, transcatheter valve, I would have kind of waited, because this is the case where it is a lesion, but it's a short, very calcific. We use a 2O burr and then combine with the IVL. So that probably will be our strategy. And in this particular case, I would try to use less in terms of the overall the use of the MCS. Why? Because all these patients do have elderly, have peripheral vascular disease, always give us trouble on the long run. If possible, yeah. If we think it's essential, then yes. So let me just quickly show it so that we are ready with accreditation, faculty disclosure, no change since our last time, and commercial support, all there. And this is the case number, I said, 198, 76-year-old male, has a class 2 angina, very high calcium, with a positive CT FFR still in the LAD, and had a SAPIEN TAVR in 10-22. So almost 3+ years ago. That time had a moderate left main, was left alone. But now has more shortness of breath, high calcium score, good risk factor control, good medical therapy, as you can see there, particularly on the statins, very aggressive in terms of torvastatin and getting Praluent, which is alirocumab, and cath, which already showed here, basically calcific lesion. Since this was a post-hour case, went to surgeon. Surgeon said, you know what, you guys should do a high-risk PCI. And this is where patient is. For IVUS-guided complex PCI of the left main bifurcation, and then we'll talk about what else need to be done with the RotaTripsy. Now, if you go with the guideline of the left main, OC point of view, as such, it will be in the rarely appropriate, R. But after heart team discussion, in my opinion, that become A. Now, with that note, as you can come back to the fluoro, please. Anu is wiring the...
So many questions. They want you to comment on the choice of guiding catheters in post-TAVR patients.
Yeah, very well. Actually, we have a very nice article, paper in 2018, Jack 18, about this guiding, coronary angiography. We actually go through the SAPIEN versus Evolute self-expanding valve. So SAPIEN is very little change. Just because SAPIEN is usually infra coronary plane, coronary risk plane, which we call CRP, and therefore it's easy to engage. And it should be the same vessel, same guide catheter. Now, once you get to the self-expanding, that's where the trouble is. Now, actually, the new self-expanding valve, which is the Evolute FX Plus, has a bigger the struts at that area of the both right and left corner. Left
special
main.
Diamonds.
So it's a bigger diamond strut, but diamond gap. So it is easy to engage, but still remain difficult in many cases. But commissural alignment, a lot of things are being done during procedure, which leads to better engagement in the future of these valve cases. But by definition, is it for the right coronary in the self-expanding? Just to say again, balloon expandable, you go with what you usually do, and then very little modification. But in the self-expanding, you want to go for the right coronary with your either no torque or with Akari 1. And for the left system, you go with the half small size. Usually we start with the VL30 or EBU30 or 2.5, and then you decide what need to be done. So one of them, now many of them, particularly self-expanding, you'll never be able to engage, but which is okay. As long as you're aligned, you put a wire, and then you advance your guide liner or Godzilla, and then you do your rest of the intervention. So that.
Andrew, can you show the app?
Okay, we'll show you that.
We have the TAVR
app.
App where we have discussed all this.
Yep, they're going to show in terms of the coronary engagement is a big issue. Yeah.
Show me that animation.
But yes, a smaller size, simple principle, smaller size of your whatever you use, EBU people use, we use VL. We use VL would have been 3.0 in this particular case, but even then, very difficult. So you should try to engage catheter with the wire inside. Don't take the wire out because you have to, otherwise guide will either prolapse or will curl up. And there are actually reports in the literature that the recently deployed valve has been pulled out because the guide got stuck. And that led to us writing this whole big manuscript about engagement of the catheters. Now, a lot of people do radial. So we don't have much experience about radial, but we did mention the radial is a little more difficult in these cases, but if need to be done, the radial gurus will do radial without any problem. We kind of discourage radial in post-hour cases, but if it can be done, principle remains the same. That for the right coronary will be very difficult. The most difficulty and I actually have, every year we get 2 or 3 cases from other institutions that they could not engage the right coronary. So, the other good thing is that you could do, which we don't do, many people actually in India do, that after self-expanding TAVR placement, they engage the coronaries by a catheter and they write down in the report. So, because these patients are going to live 5-10 years and they'll come back. with some coronary event. So they do write down that which catheter will going to be good for them. That is the JR, JL. So they do mention in the cath report. We don't do it routinely. Now here you can see the IVL will not make a turn. The IVUS will not make a turn. That's okay, don't push it. Because of the calcium.
All excellent tips. Another question has come
1.75%, right?
with the possibility of involvement
175.
of the circumflex.
Yeah.
As you are doing the LAD rotational ablation, you want to put the wire in the circ.
Yeah. So very
when
good
you are
point.
doing rotational atherectomy, of course, you cannot use, wire in the side branch because it can cut that wire.
Yeah.
But, then otherwise you need a 8 French guide and put a 7 French Godzilla.
Yeah.
We have never done that.
Or over the so Godzilla or over the wire system to cover it. So people have used, I call it a crazy approach. Because I can tell you, once you do a rota of these cases, there is a very little plaque shift. And that is what the advantage of the rotational atherectomy is. Less plaque shift, so you don't need to worry about the side branch. Side branch closure has been reported. We have published 2 papers on that. Much lower with the rotational atherectomy compared to if you just do a balloon angioplasty. We don't have much experience on the IVL in that situation. But yes, this is what we usually do. So in this case, I would not worry about. Somebody wants to do 8 French, put a Godzilla with a wire into the circumflex. It can be done. But I can tell you the day and night complex cases, we have never regretted that we did not protect the side branch because side branch can always be accessed like in this particular case. So we'll not do the wire there. Yeah, uncovered wire cannot be left alone because rota will cut it. You can use IVL, you can use a laser, but both orbital and rotational atherectomy will cut that wire and should not be left alone.
Going back to this case, Samir, if this case we are doing if it's not live, we will not be imaging. And we will do rotational atherectomy both branches first, and then only we may do imaging later, because we know in this kind of calcific severe disease, you will, based on just angiography, there's so much calcium. Okay, you are going to do some kind of atherectomy.
Because look at the IVUS did not go.
In the meantime, Dr. Kinney has put up the information. Extremely useful, really. Pull it up. This is
show the first picture of the tower catheter.
Years and years of expertise for exactly this kind of a case. Anu, I am so glad you put it up. Beautiful. Beautiful. I mean, that's exactly this whole case.
And you have to show the SAPIEN 1 second.
Right.
You have the wrong animation. Show the SAPIEN.
And the questions which have been asked.
Yes.
So if you see here, let the animation play. So what you need to do is, you see how that wire is, right? So you go underneath, you go through the diamond. See that we are doing this is bird's eye view. You rotate it, get through the diamond. That's how you will engage. This is doing PCI. You have to show engagement of the...
Anu, whoever made this animation, just magnificent job. Magnificent job.
It's a KTT. You know what is KTT?
No.
Kinetic tank.
Fantastic. Fantastic.
This is the PCI he's showing. You have to show the engagement.
Samin, yeah.
It's not in the slide?
No.
Oh.
I can get it.
Yeah, do it. Do the engagement with the guide both for the SAPIEN as well as for the self-expanding. When we did it, of course, the newer generation of the self-expanding valve was not there. The current self-expanding valve, as soon as you have commissural alignment, you see the diamond so that they're easier to engage. So we are ready here, and I will go through that, how to engage with the... I think somehow Andrew had predicted. He told me, you may need me today, and he's sitting right outside. He is going to make the slide of that animation right now as we speak. Now we have 175 bar ready, and I'm just going to start doing the 3 steps are okay. Okay, there, and let's just...
What's going on?
150, 5 seconds, 150, 45, 10 seconds, 150, 15 seconds, 150, 20 seconds, 150, 22, 26, 29, 35.
So if you see here, right, if you see that, there is this second lesion just after that diag. So I think we'll take care of that one too.
Anu,
But there is disease way further down, which we will not.
No, there is a tight lesion. We have to take care of that.
No,
in the LED.
proximal. Yeah. This is a distal lesion which we are not doing.
No, but at 1 o'clock.
No, this is nothing.
150,
Yeah, beautiful.
I know, but this burr, I think is too small for that.
Yeah, that's okay.
Samir, you are asking a question.
Yes, specifically, it's such a useful tip for people to follow how in the background somebody is reading out the speed. At the moment, there was a drop to 145. You think that is exactly at the, that angulated eccentric part?
Yes, of that LED.
Samir, many questions have come. I'll quickly read all of them because it won't be fair to the audience. Dr. David Zerpa has asked, which makes more sense, always rotational before IVL?
Yes.
Yeah, that's a good question, and that I'm going to show the trial also. That should you use IVL in every rota, or you can just decide, let's do the LED,
Take a picture.
modify. Or you just do a cutting balloon, and some cases leave IVL for some time because of the cost associated with it. Have you taken care of the second lesion?
Yeah, we did.
Okay, good.
Wonderful.
Not the distal.
No, that one, yeah. Good.
Question is, we use rota wire, or you are saying use IVL to the side branch?
IVL circ could be done with us. IVL, good. Let's come out with this.
Okay.
Yeah. So question is, for the circ, you want to image and see, maybe use IVL for the circ.
I mean, before the era of IVL, we would use the same wire, go to the circ and do rotational atherectomy of the circ.
Yeah.
Samin, question from Dr. Amiri Pua from Tehran. Any use of orbital here?
Yeah, could be, no problem with that. This is a big vessel and can be done with the orbital also. No, those who are orbital expert, nothing wrong in that. Actually, it's a large vessel. This is the rare case where you want to go to a bigger burr. Will be no higher speed. Will be no issues also.
You've covered it already, but another question, the use of rotational in this kind of a case via radial. You've already covered it, but...
7 French, because this is a case, unless you're trying a mini DK crush, you need a 7 French. But yes, mini crush will be, but 6 could be done. 1.75 burr will go through 6 French, and radial could be done also. Not a problem.
Another excellent question again by Dr. Zerba. Where do you draw the line between adequate modification versus too aggressive in left side?
Very good point. I can tell you, until now, this is what the AI has to help us. In imaging, you have done some calcium fracture, it should tell us you are done, or you need to upgrade it, or combine it. So this is where I would say the AI has to help. There is some people think that if you got a few fracture, that's good enough. And so forth. But some people will say that, you know what, you have to have at least 2 or 3 fractures, and as long as there is no medial dissection, is fine. So it's all, a lot of theoretical, but it's a gut feeling. As long as you have created 1 fracture, 1 or 2 fracture you have created, I think you can stop. But if not, you can always do the balloon and cutting balloon. Just don't go very high pressure. And if it still remain, then you upgrade to the burr, or you can just go with the IVL combined. I always tell them, in this day and age, your second rota burr is IVL. Very rarely go with the 2 burrs.
Anu, exactly the kind of things you would be looking at AI at your institution, your new center?
No, I know Dr. Sharma keeps using the word AI should do it. It's not that easy. I know people are talking. AI can be used in lot part of, but in clinical decision making, where human brain actually, you understand what is deep learning of the AI, which is neural network. I mean, I still feel when it's coming to making this kind of decision of the neural network of the human brain, we are far, we ourselves, we are learning with especially the decision of, which kind of
Very wise comments.
OA, okay? Every time is the same question. So we ourselves don't know. What do you expect AI to tell us? AI is from what we are training the, right? The module has to be trained by a human. You're not going to treat another human by some machine telling you what to do. That cannot happen. So that is the number one question. So the question they were using, so that's why Will is trying to tell. Remember, you always used to say how people can follow the hands, the hand movements and learn like that. Now the KTT brain also is important, so they understand how the brain thinks. That's They're laughing. No. So let's go back to the point is their question about how do you know which whether it is OA or RA. Like we said, it all depends what you're comfortable with. We are very comfortable with Rota. We know how to do it safely, and we have shown it. Then we can show with the imaging what rotational atherectomy does. I'm going to image and show you. It does, I would say, nice finesse cuts. If we are not happy, because if you with IVUS, you can never understand. Have we done it well or no? OCT will tell you the calcium thickness and the amount of what atherectomy has done. What IVL definitely does when it is more than 180 degree calcium or closer to 360 degree calcium is some amount of deeper cuts. And what we have been seeing, because we are doing our own trial, nodule shock. In nodule shock, what also, and other so many cases that we are doing, that if you are 180 degree calcium, that you see at the level of the where the calcium is meeting the fibrous tissue or all these things, you definitely see deep medial cuts. Going back to the point, if you see any kind of deep medial cuts, it's telling you that stop the procedure right now, means don't keep doing more calcium modification. It's time to take care of it with a stent. Kiski, do you want to add anything?
No, it's perfect. Thank you so much. So, perfect. You did perfect. So, yeah.
Okay. So, we're going to do the IVUS of the LED now. Come out. What AI can do is the way we train the module. Until we humans don't know, and we don't know how we are going to train the module, it's a long way to go. You are asking some question.
All of them got covered with your excellent explanation, Anu. All of them were asked in different patches, all got covered exactly like what Kiski said, all covered.
Now, question, the other thing is we have covered a part of this during our imaging. So people actually should go to our imaging live webcast. So, last week we had over 50.
Do we check the mid LED also?
He wants mid LED also. Okay, we're going to mid LED. Means because we are showing step by step with enough data as well as our experience using the app, how to take care of calcium.
Okay, start fullback.
Yes.
It's a mid LED. Even here, a lot of calcium, 360 calcium. Yeah, in the pullback, yeah, some nodule here in the Prox LED.
This is the ostial LED now, yeah.
Yeah, I see the nodule. The surface is ablated in the left main. Yeah, got it.
Now, in the imaging, right, we use the word calcium thickness. But I think in what we call as the pathological data that we have, they do talk about the type of calcium, right, Kiski?
Yep.
Can we understand that not just the thickness?
So can I explain?
What do you think now?
Yeah, so I show you. Yeah, so I try to start from the left main. So the proximal left main has some protruding calcified nodule, but area is like 16. And I go distal left main. There is a lot of calcium. Now you see the big branch. This is the circ from the 2 o'clock. So before that, it means that distal left main actually remains fine. It's 10. There's a lot of plaque, but distal left main is fine. Then after the bifurcation, we see the calcium nodule protruding inside, but the surface is shaped. This is what the rotor done. And
Can you again explain when you said shaved, because that is what people want to learn. What are you describing? What is the meaning of this? Is the term we started using the word shaking or shaving.
Yeah.
So Rota nicely shaves when you do IVL. Remember, you are using the ultrasonic waves, which we said it is shaking the calcium plate or the nodule. So go back, show exactly what with the arrow.
Yeah. So of course, yeah, great point, Dr. Kinney. So we want to see the comparison of the pre and post. Actually, the pre-initial IFS didn't close. I like that Dr. Kinney didn't forcefully push, because that might like stack that calcified nodule. This is safely done. So this initial image is after the loaded. But you see the like 6 o'clock to 9 o'clock, the surface of the nodule is like artificially shaped like an arc. This is the one like a rotor did. The surface is shaped. And other point is the other half of the vessel is like plaque free. So this is very dangerous. Yeah, one arc is protruding calcified nodule, but other half is plaque free. If you do aggressive like a super high pressure balloon, it might injure this plaque free part. So we should still be cautious with some modification.
So this is the distal left main, right?
Sorry, this is the ostial LED.
Okay, ostial LED. Now go a little bit inside. Okay, a little bit inside.
Yep.
Almost proximal.
Yep.
Okay, now you start seeing 360 degree of what is called as a calcium plate.
Yes.
Looks like we did not do a lot there, right?
Yeah, because 360 calcium, but area is like 7.8.
Okay, so that's why 1.75 bar did not do any kind of modification. So at the level of the nodule, Rota has done shaving, but at the when you go to the proximal LED, there is that 360 degree calcium plate, large, the diameter is large, so we will need to do IVL. What we are trying to say is the question that's being asked. When you think we have done enough modification? We have not done the modification here. We have taken care of the nodule, but the so-called vessel, we have not done any modification. Now go back to that proximal LED and show me the diameter. Right there. It's like 3.1. There's no way we are going to do any more rotational atherectomy. No. So what we need to do is IVL at this level. So let us use a 3.5. What do you think of Kiski, or 4 you want?
Dr. Kinney, now the point is the tightest part is the ostial LED, and the separately in the mid LED, the gap of that part is actually area is okay. Do we intervene here or separate stent?
Give me the mid LED, proximal LED again.
So this is prox LED. The area is like
ostial LED, not prox.
Ostial is definitely tight. Still area is like 3.4.
No, that is taken care just inside the ostium, where you start seeing the 360 degree calcium.
Sure.
Okay, right there. Okay.
Yeah, here.
Yeah, see, it is still. I think we need to do IVL, no?
If you intervene here.
We need to do IVL there.
Yeah.
Yeah, 3.5. But before doing that, open the 3.5. You're okay with 3.5? I don't think we need to go.
So other point is 360 calcium. That's why we don't see the EEL real vessel size. But even the lumen is 3.5. So 3.5 is good to shock this 360 calcium.
Okay, 3.5 IVL. Open that. So we're going to do that. Then the second lesion you were talking about after a little gap.
Yeah. If you want to cover like one stent.
No. Show me the second lesion first.
Sure. Like this.
Okay.
After the branch, here also we see the 2 o'clock, the small diag. After that is here, we see some eruptive nodule here, like the irregular surface and the protruding inside. This is a eruptive calcified nodule.
So again, 175 bar, I don't think has done anything. So we will use the IVL again, right? For modification.
This is
360.
Yeah, definitely IVL work for here.
Now, can I do the circ also?
Yeah, we didn't check the IVS.
Let's do the circ imaging. Are we clear what we are going through?
Absolutely, Anu. There are questions though that with what you have shown and what imaging has shown, why not upgrade to a 2.0 burr?
I think Dr. Sharma, before he left, he made the comment. Remember, the second burr is IVL. So go back to the point. Let me tell you why we can't do IVL. Go back to that proximal LAD, ostial to proximal LAD. The diameter there is already 1 point. This is a proximal LAD?
Yep, after the nodule.
Yeah, but look at the diameter, 3.0. So no point doing a 2O burr. Okay, then you are not going to take a 2O burr just to the second lesion. Instead of that, if we do IVL, then you can take care of both that ostial LAD and the proximal LAD lesion at the level of the diag. 3.5, that's why we decided 3.5, because diameter is just about 3.2 to 3.6.
Anu, another question. Before using IVL, you want to protect the circ with the wire?
No, that's what I'm doing now, and I want to image that
Image
also,
okay.
Because if possible, we can use the same, because there will be 12 pulse, right? I want to see if we can use.
Anu, there is a comment specifically about you. I'm going to read it exactly as it has been posted by Dr. Ismail Imtiaz. I've been practicing in a small town near Dallas and started doing rotational atherectomy after watching your videos. I follow the 3 steps which Dr. Kinney mentions again and again. So far, so good. God is kind.
See, that's what we feel. We are teaching the doctors across the globe, and they are able to take care of tough cases, which means indirectly we are helping patients across.
Absolutely.
Yeah. Some die there now. So this is where wiring the circ.
Kiski, question for you.
Sure.
Since the distal left main was kind of borderline, would you have also used OCT here?
Yeah, but for the lesion severity assessment, IVAS has a class 2A indication based on the more data. Of course, OCT can also check the area, but from the data, IVAS is more reliable to the left main assessment.
What he's trying to say is in the guidelines, optimization, all this, IVAS has more data in outcomes than OCT, though right now a lot of trials have been published with OCT. For the guidelines, OCT is still making up for a complex lesion is for more of an optimization. So what I was talking about is with the imaging, that is in vivo imaging, we still cannot understand calcium composition, right, Kiski? But when you do CT scan and pathology, of course, they'll talk about calcium composition. See, one thing, if we can understand calcium composition with imaging, then of course we can decide.
Anu, people know a lot of information. Congratulations have come in here for your birthday.
Oh, thank you.
Okay, start pullback from the circ. It's coming. Big vessel. Yeah, osteo circ. Yeah, I'll stop it.
It's good?
Yeah, wait a minute. Huge size of the circ. Yeah, osteo circ also has a calcified nodule. Here is a
ostial circ is calcified nodule, but look at it. Only nodule, but there's no calcium around, right?
Yeah.
Yeah. What would you suggest? This is a kind of situation where, and not even that, we call this as a massive nodule. Our definition of massive nodule, which is mine and Kiski's definition, is the nodule is taking more than 90-degree arc. You see that? Go back to the ostium of the circ, where you see that nodule. Yeah, look at that. Almost, would you call it 2 quadrants? Almost 2 quadrants.
Yeah, very extensive.
1.5 quadrant.
But this level, the area is like okay, like 6.6. Then kind of more proximal. Okay, so
proximal circ has some calcium, right?
Sorry, Dr. Ken, it's opposite. So this is the level of the left main bifurcation because I see the LED wire from the 7 o'clock. So this is at the level of the left main bifurcation. Now I go a little bit inside. Yeah, so this is the exactly osteal circ. Here is like 270 calcium, but Dr. Kinney, the area is like not that tight, the osteal circ.
No, why you say not tight? Oh,
Yeah, so
there.
this is the osteal circ.
6.9?
Yeah, and the nodule, that's why angiographically looks hazy, but
Yeah.
area is not that tight. That's the I was finding.
Would your suggestion be to leave it alone?
That might be the option.
Okay, let's do the LED. I think, with that amount of calcium, nodule in the LED, nodule in the osteal LED or left main, the subsequent PCI of the circ will be very challenging if we stent across. That's what I feel.
Anu, here is your sample of your contributions to imaging. Questions are coming specifically addressed to Kiski today. Here is Kiski, the question for you. Have you any experience with clear IVUS whereby you fish saline during IVUS runs? Does it help or not useful?
Go.
So you mean saline flush during the IVUS pooper?
Yeah, clear IVUS.
Actually, we don't do that.
Okay.
Yeah. If we prep well for the IVUS, we don't need to clear that one.
C2. Yeah. Go. 6.
Anu, another question for you.
Okay, down. Yes.
What criteria would you use to size your IVL balloon? Media to media or lumen area?
I like lumen area, and that's why I think Kiski was also saying he could, because of the calcium, he could not get the EL, right?
No, yeah, correct.
Could not. I would not go media to media. That's why we were discussing 3.5 or 4.0 lumens. Okay, good. Go up here. So we did one pulse. Again, same 4. This is C2. Although we carry the arrow, we have both. The newer one, you can go with the easy deliverability one, and you go only 2 atmosphere. All they say is, as long as the balloon is delivered and you have just inflated to 2 atmosphere, you can give the shock. Yeah, that's good. I think that's good if it's done the job, right? Then we go to the second lesion. Okay, now let me do this. Oh,
needs more preparation, huh?
Yes.
Amazing.
So much calcium.
I didn't think that would happen.
You see how the Rota did it, and now look where we are.
There you go.
No,
it hasn't crossed. So maybe a high pressure balloon there too. Anu, another question for you. They are pouring and pouring. That should there be anything special? Again, this is coming from Dr. Zarpa. Doing IVL for left main, any particular precautions, any care you take, or just everything else which you do in other lesions?
I mean, the question is if it's really tight and you have not done atherectomy, right? Like we did here though. Okay, good. Okay, go up here. There's a chance you can develop EKG changes.
So very, very important step there, that lesion preparation for IVL is so critical. And Dr. Kinney did not push through with the catheter, which was already there. It came out high pressure, and I think it will go easy now.
Huh? No, we just almost halfway through. Go up here. Okay, so you see that first one pulse took care of it. We are giving a second pulse because there is no data to say that once dog boning is gone, do you need to continue giving pulse versus you are done. Based on my experience, if your dog bone is gone, you're done. Okay, let me show you here. You don't need to give all the pulse. You see that, right? So I went in a little bit. And now we finished our, this is 4 pulse done so far. Now you see here. So 4 to 6. Now this is 6 atmosphere. I think we are done here. I'm going to come out.
Opened up quite nicely too.
Yeah. So we did 2 in the osteal LED, 2 in the proximal. Let's take a picture. And we'll go to the circ.
Excellent.
Yeah.
Excellent.
So that's
Just
done
the
that job.
size of the vessel and even the circumflex is looking so much better. And I don't think there has been any plaque shift. Not at least angiographically.
Yeah. I think, do you agree that we should take care of the circ, though he's saying the lumen is okay, that for the future, with all the issue in the left main and LAD, it may not be that easy to get into the circ. We will do the IVL and take care of it. Now, if somebody says, I don't want to do IVL, we'll do cutting balloon, because, the only question there is, it's a massive nodule. The term massive nodule, I said, is more than 90 degree. There is, again, debate what kind of modification you need when there is a nodule. We still believe that if there is nodule and there is an arc of calcium around it, which there is not an arc of calcium at the level of the nodule in the circumflex, you can use IVL, OA, Rota. But if there is an arc of calcium, you first need either Rota or OA and then do IVL.
Don't think there is a role for it, but I think since the question came specifically, I should ask. Any considerations of DCB to the left circumflex?
I mean, no data for large vessel, right? That's number one. With this kind of calcium in the proximal vessel, I think we will be a little bit uncomfortable leaving something like that. Okay, let's go with the, I'm going to do, ready with the IVUS, right? Let's do the IVUS quickly. Yeah. No. First IVL, and then after that, I'm going to do imaging of both to see what has happened.
So Dr. Ravi Kiran observed something very nice. I think it's important that the circ must be looking good because the wire went so easy this time.
Okay, go. How much? Yeah. Okay, go up. Okay, good. Go. 6. See there? We don't need to do much. Down. I'm going to do one more, which is not necessary. If somebody says that's it, I'm coming out, it's good too. I'm going to do more in the distal left main, and that's it, we're coming out. Okay, go. Good, go. IVUS is flushed, ready. Okay, down. Okay, let's finish IVUS of both vessel, and we are ready to stent.
I know people are ahead of you here. They are already talking about Mini-Crush versus Colette.
I know we are always teaching Mini-Crush. Culotte is an issue because you definitely will have a 2-layer of stent, no matter what kind of a culotte, how you want to do it.
Another question, would you consider Onyx for its superior radial strength?
Not Onyx, you mean Megatron.
Megatron also?
Yeah,
the choices are given both Megatron and Onyx.
Synergy Megatron. Not Onyx, yeah. You have Zions here? I would go 4-0. You think a 33 will cover left main to that prox LED?
Just protruding left main 3 millimeter.
Huh?
If we use the 38, because the distal to the mid lesion to the ostial LED is 35.
Oh. So get us, I think I'll do a 3-5.
Can I hear it?
Right?
Hear.
Okay, now this is the second lesion.
Okay.
Is it okay working?
Start feedback. Yeah, this is 360 calcium, but area is good.
I mean, exactly how we felt, a flurry and flurry of questions today, and want to thank our very sophisticated audience today asking some excellent questions.
Wow. They're all,
Yeah,
I can tell you any time when Dr. Also Fuster used to go to India, and we know that India represents a big number. Our 30% of our 35% audience,
to the
America is 45%, and he always felt very intelligent crowd, and specific questions and so. With that note, I mean, and our purpose is also to show step by step what is going on and to perform the procedure appropriately.
And get us a 15 or 18. 35.
Imaging again?
Yeah,
We are doing
I see
imaging. What have we done? Anything?
big calcium fracture in the mid LAD, 7 o'clock. This is a calcium fracture. It was not before. So IBA worked for the mid LAD. And the osteo LAD, there's some like a flap between the calcium and the fibrous plaque. And the lumen is much bigger. It was like 3 point something. Now it's 4.9. This is an osteo LAD.
Excellent.
Yeah.
So what did you say at that level of that?
Mid LAD.
No, not mid LAD, I know. Proximal LAD I want. Ostial to proximal LAD.
Sure. So you see some like a flap here between the calcium and the fibrous plaque. But by the IVUS resolution, we don't see the calcium fracture on the calcified nodule. But this is a limitation of the IVUS. Even OCT, sometimes we miss the fracture in the nodule. That's why some papers said micro CT can tell.
But I know, but you think it is a medial injury there?
Not that medial. So it's a intimal flap between the border of the calcium and the fibrous.
Intimal what?
Flap. Intimal dissection.
Huh?
Flap.
Okay. Okay, let's go.
Which would be to be expected, no? Nothing.
No. What I'm trying to tell is there's a lot of hype in the social media that is going on that after the recent trials that were published.
Okay, start feedback.
Shortcut, right? You're going to show. Where is IVL versus cutting balloon? That IVL does not do medial injury, but what we are seeing is exactly if you have 90 degree, 180 degree calcium at the angle, exactly where the calcium and fibrous tissue is, we see this kind of more medial, deep medial cuts and injuries. So we have to be very cautious, which Kiski already said. Remember, there was nodule and there was no calcium in the opposite sides. This is a kind of area, there's a risk of perforation. So very cautious when you're doing cutting balloon, high pressure balloon, or post dilation with the stent.
Okay, let's put a stent ready.
Yeah.
So Kiski, from medial injury point of view,
Yes.
how good we are the OCT to identify the medial injury? We know they are very good with the calcium fracture.
Yep.
But what about the medial injury? Can we identify that? I know it's a lot of histopathological post-mortem studies, but can we clinically identify medial injury by OCT? We know with IVUS will be very difficult because of the calcium there. Yeah.
Yes, because that superficial assessment, like intima, media, adventitia, OCT is like 10 times higher resolution. We can more clearly see the medial injury.
Okay. All right. Ready with the stent for the circ first?
No, I need to see what Shirk showed, imaging.
Yeah, circ is much bigger lumen. This is again same, like a calcified nodule. On the nodule, we don't see the like fracture based on the IVUS resolution, but much bigger lumen compared to the pre.
That could be effect of the balloon. So essentially, we didn't do anything much in the level of the circumflex. It was only nodule, nothing there.
Okay.
Actually, it's 6. MSA was 6.
Oh.
Yeah, so, but what we felt is that since left main to LAD, once we stent, then taking care of the circ with that kind of a calcium and even if it's a nodule would be difficult. Okay, so we are going to go with the 38, right? Kiski 3538 from left main to LAD, and we'll do a 3518, or let me take a picture. Did we take a picture here? Okay. Question is 15 or 18 to the circ. Ready? Wow, even a 4-0. Circ looks very big.
Yeah, and actually circ lesion is very focal, like 9 mm.
Okay, so 4O, do you have 4O? 15. And LED, we are okay with 4O, or you want me to, 3.5, or you want me to put 4O? Because left main, look at the size.
Yeah,
about
correct.
6.
Correct. Just the landing zone is like 3.3 lumen.
Okay, so then we go 3.5 to the LED.
38 is almost like side by side, like just 3 mm in the left main. If we want to cover
Oh,
one
so
stent
you're
to the
saying
mid,
go 48?
it's kind of too long because based
Or
on
you
the
want to put two
IVS,
different SS?
left main to the distal,
You want
I
to
mean,
put a
after
shot
the
there
mid lesion
and
is
then like
40
that,
millimeter.
4O. You know what, let's do to a shot. Give me a 3.5, 15,
Okay.
right? Or a 12, right there.
Circ also will require 2 separate stents.
We're going to do 3 stents. One to the mid LED.
Yeah.
We'll do a 3.5
Yeah.
because he's saying distal is barely
correct.
3.3.
Okay.
So we'll go 3.5 to that LED at the level of the
correct.
diag. We're not
Yeah.
going to do anything to the diag.
Good.
And then we will put 4O, 2 4Os.
Okay.
3.5, 12?
Yeah.
Okay.
But the OM is small.
Not OM.
Are we doing anything to the OM or no?
No. We're
Oh.
not. We are just focusing on the highway.
All right.
We are only focusing on the highways.
Okay. So Samir, keep asking the questions. I know you said that a lot of other questions have come up, so we can answer that also. Yeah.
We've been
Anu
answering.
has answered
Okay,
all
good.
of them.
Beautiful.
We are completely caught up with them. There are, Samin, there was a question which I held off because I know that is what you are going to talk about. Several questions about use of cutting balloon here.
Yeah. Yep. Use the IVL earlier or no?
We did.
Okay.
We did IVL for the mid. That's the only place where IVL has done. We can see. And then after that, prox LED, and we did it to the. This is 12. Wow, so short. Anyway, short. And then we did the circ also, though MSA was good enough. Some die.
Pull back.
Yeah, good. Okay,
Good.
go up.
Go up.
Anu, a request also to you specifically to explain in detail the sequence and the steps for the Mini-Crush.
Yeah.
Again, sure.
Left main Mini-Crush, Andrew. So one, he's going to show you step by step. Okay, all our animation.
Just few millimeter back.
Okay.
Yeah.
Okay, good. Down. The MS is large here, though there's calcium. There was a discussion why we are not doing a culotte. Okay.
Yeah. So I can tell you that if the discussion should be that Mini-Crush versus DK crush, by overall, the culotte actually has not favored in the left main. I know a lot of people do it, but yet to see a positive trial of the culotte. Actually, we have few negative trials of culotte, particularly DK crush 3. Remember that compared with the DK crush against culotte, and it was negative. Culotte was inferior.
4023.
23?
So to the
No.
audience,
What do you want?
watch
28.
the
Okay,
animation.
4 or
there.
28.
Yeah. Yeah.
So you wire, you pre-dilate. Always we say pre-dilate side branch first. So here, remember, it does not matter, but always go to the side branch first, because often side branch, angle and all that taken into consideration. Then you go to the main branch, which is left main to LEDs. You're dilating circumflex nicely. And once that is done, you'll take out the wire, right? Good. Now you'll go with this dilation. You see that? Left main to LED. That's good. So we actually updated this and we are doing POT. So now rewiring, we have done before the POT, but often people say we want to rewire after because there's complete proximal optimization. The risk of wire going underneath the stent strut is not there. That's acceptable too. So then you will go. So you do the proximal optimization. Then you take 1-to-1 balloon size of the circ and the LED, and individually you go, and then you do a final kissing. What we don't do, and this is what I am saying, that is a report. And that is what I think we have a couple of publications, especially a review article, because the so-called report has no data, but somehow people have just made a life out of it. Talking report.
No.
talking
And
about.
we actually showed that kissing balloon is better than even report from the symmetry point of view, because biggest question is, no, what are you doing now? This
First to the circ.
This 4-0 what?
Come, give me 4-0.
4-0-28? No.
4-0, 15, 18 to the circ. 4-0, you have 15.
That's what I thought, yeah.
Circ.
Yeah.
Is it clear, the steps?
Absolutely. Wonderful animation.
And we'll show that now step by step. Yeah. Go.
That's why people should open the app in some of these very challenging cases, so you are seeing both the live case as well as the animation to guide you.
Actually, very interesting. We just last week, no, not last week, this Saturday, Dr. Fuster has a big, his ACC conference, you know, the cardiology conference, 1,000 plus people, and about 5 of them from outside. Actually, one was from USA and other 4 from outside. They came and showed that how useful our CCC live cases are. It's just amazing for them. And one guy actually from the United States said that we have it in our cath lab. So anytime we are doing these complex cases, our app is playing and cases are playing. And of course, they watch it every month. And so anytime even we have count of, let's say, 20,000, truly there may be 35,000, because many places like 30, 50 people are watching it. It's not one person watching. So that's about very reassuring, very, very reassuring. That our mission of global teaching is not enough.
What is not enough? It's good.
You're
not covering. No, you're not.
No?
No,
A
no,
little
no.
more, or you're good?
No, it's not even going. Forget
Yeah.
it.
No, it will go.
It's not.
Put a stent in more in the circ. Good.
I have to see that.
I think we might be okay. And go to epicranial.
That's why I wanted 23. I knew that. That's
No, but
so
it will
much
not
cal-
touch. Even this one may be short.
No, we are not. We are giving a gap. There's
Oh,
no
we are
way. we're
giving a
gonna-
gap.
Yeah, I wanted
No,
a
you
shorter
cannot
one.
leave the gap in the LED. How can you leave the
Please.
gap?
No, it's not deceased.
Okay, but we have created some trauma.
That's okay. We didn't touch that.
No, with the
Other than
balloon and
rota, we did not touch it.
Yeah,
Okay, I think that's good enough now.
yeah, good enough.
Connect.
Going to the caudal again.
So you will have a millimeter of the stent that will be protruding into the left main. That's it. So this is not a good angle. Looks a lot. Okay, this is the right angle. You see that? Take a cine.
Looks good.
Looking good. Okay.
Yeah.
Go up on the circ. Get me a new fielder wire. This is
Okay.
yeah, go up. And then get us a 458 high pressure balloon. Down. What's the left main size?
Yeah, like five more than 5 vessel.
Wow.
Yeah, 4.5 is good.
Yeah. Okay, good. Down.
I mean, several comments. It's amazing how they have been following on each word you say. They're talking
Come
about
down.
the gap.
Come, pay attention.
No, I would say that in this day and age, there's no
go.
reason to leave the gap.
Go up, go up.
That's for sure.
Okay,
So a
go.
lot of people actually coming, they're doing that, even come to the ostium. Just finish, because why you're leaving any gap? Because we know unstented area will have some restenosis. It's
Down.
small, but yes.
That
Because-
expanded very
yeah.
well there.
Yeah. Yes. Mega. Nice expansion.
So coming up to the ostium, always have an issue. You have a TAVR valve. Then you have another stent. Too much metal.
No, in
You know,
this
there
case,
is
no ostium.
no.
Yeah, this case is no ostium,
You
definitely.
come up to the ostium, no matter even a millimeter that's sticking out, subsequent engagement and all that is a trouble.
Yeah,
If you
so-
can avoid it, yes, I would
If
say
possible,
avoid it.
yeah.
Yes.
And that is
Okay, now
what, in Europe is very common. Why are you giving injection before the cine? Yeah. They get worried about a little bit noise. Weight noise, you have to take a picture, my friend. Yeah. Yeah. Wow.
Samin, what
Yeah.
about proximal ostial LAD? There is
Yo,
still
no,
a-
that's where, yeah,
the
that's why
superior aspect of it.
this 4.5 balloon is going to work there now. So this is a kind of case you can do a pot. So you want to get a new wire?
I'm getting a new
Okay.
circ wire.
New fielder wire then.
So just looking at it, what do you think you have a residual calcific nodule there
Nodule,
still?
yeah,
Or
absolutely. Yeah, it's still there. But remember, even you shave,
Mhm.
it doesn't go away. From, let's say, 2 millimeter projection, it may become 1.6, but remaining, it still remain there. Not
No,
far
what
first.
we also talk is we collapse now. Give the 4.5 balloon.
Okay. So we are doing a pot
Definitely
and then
collapse.
recross.
Yeah.
Yeah.
In the imaging, what do you see, Kiski? Once there is, we call it a massive nodule. It's not even 91 quadrant.
Yeah,
It's
yeah.
more than a quadrant, almost 2 quadrant.
Yes.
This is our own definition.
And the question always comes that for calcific nodule, which is the best technique? I would say from IVL works very well, both orbital rotational atherectomy work very well. Only question comes is that orbital versus rotational. Nobody has clearly shown it, but there is a feeling that orbital might do a little better job of shaving the plaque compared to rotational. So maybe that's what
Okay,
still the plaque is left there, which we know.
Anu,
No. I disagree with that.
No, I'm saying so a lot of people
No.
believe in that. They
People
have the
believe.
algorithm showing that if there's a large nodule, you go with the OA. I mean, I agree with that. I don't agree with that. I agree that I don't agree with that.
Down.
Anu, a chorus of people complimenting on your teaching and the skills of the case.
Go up.
Beautiful.
Okay, down. There used to be a follower. Always. He used to put comments. The goat. Go up there. You need a new 3.5.
Oh, no, 4.0. 408.
Oh, yeah. No.
408 high pressure.
Samir,
Where to?
we have
12,
covered
12.
it.
Yeah.
12.
But still, would there be any role at this moment for the ostial proximal LAD to put a cutting balloon?
Yeah, I would say if you need here, because I think the expansion has been there if you need, because that's a nodule there. Cutting balloon will work in the nodule, but now it's behind the stent stud. So if you want, you can use a 4.0 IVL.
Right.
So if I have a choice, we learned that more and more places, cutting balloon IVL do the similar job. So in that particular case, I will go with the IVL 4.0 and then post dilate with a 4.5 balloon again.
Excellent.
That's what I would do.
Okay, let's understand, right? What is IVL going to do or cutting balloon you want to do there?
No, it's the fracture, calcium fracture of the remaining nodule. That's
Fracture has been done when we did pre.
I agreed. But now you have shaved quite a bit. Now there's still a big nodule at the bottom.
Yeah, but there's no space for the nodule to go anywhere. You just think it's a big block of concrete that's sitting there. You're trying to get rid of it. Either you have to go inside and remove the concrete completely, which you cannot. There is very little space. It's just going to sit there, spread itself. So it's not. It is going to remain like that. By doing IVL, we are not going to achieve anything.
Angiographically, the key is that angiographically still looks a little nodule, which we'll do by the IVUS. And I'm just saying that if you want to flatten this nodule further, if you want to, because the lumen is only 5.5 or something, that may be reasonable to do IVL here for that purpose, not the cutting balloon. That's it. That's the point I'm trying to make. Because here cutting balloon will not work. Why? Because the energy of the high pressure will not go behind the stent studs. Acoustic energy, laser energy will go. So that's where the principle will be of the non-cutting balloon technology in this particular case. Yeah. Now, no matter what you do, you may still be left with, because where is that base of that nodule is going to go? Yeah.
That's what we're saying.
408 or 12?
4.012 high pressure. No, so that is one. And
Anu, here is something which ends this conversation. By doing anything additional, you are exceeding the chances of a perforation.
Absolutely.
Yeah.
no, we predicted that in the beginning with the imaging, because at that level that we saw the true ostium, there is a nodule, but there was no arc of or calcium plate around it. Kiski has shown that. So, we have to be very cautious not to go real super high pressure there. Now we need a 4.0. You need another 4.0 to the LAD.
You can use the same 4.5 low pressure.
Now let's see if this will go. So this, even we wire.
It was a little difficult to begin with, yeah. Just see where the wire is in the center of the struts or no?
Okay, this guy is like.
It looks okay. Yeah.
No.
You want to put a wire in the.
I hope you all noticed the collimation there.
Yeah.
Such practical ways to, I mean, that's how you get durability of working in a cath lab for decades. Radiation protection.
Samir, I really don't know how many people use collimation.
Yeah, I think we need, its role is so huge. And, you know, it's strange that I'm glad I noticed it, but you use it very often and very intelligently. You know, it's reduces it tremendously.
I was originally trained in England by a radiologist.
Yeah.
That's why I'm so particular about how you position the camera, the height of the table, everything for radiation protection until I came to America.
Yeah, I would say that until 12 years ago, there was a survey. About 9% of the cath lab in America were in the radiology department. And I know that back then, when I was a fellow, went for the interview at the at Loma Linda, and they are actually with the Peter Sonnenblack, the cath lab was in the radiology department. In 1989, I'm talking about. Of course, things have changed, but it's still few places. Cath lab still is in the radiology.
You have a 2 or 12 balloon?
Yeah.
Then we can try.
So much to learn from other specialities. I'm actually observing.
You see that?
Yeah.
We rewired completely and we were able to get it down.
Yeah. So stroke alone is, unless you combine with the acute MI labs, of course, sometimes it may be a little trouble from that point of view. Let's dilate. No, but dilate here a little bit.
No, other balloon may not go. What's the other balloon we have for the left?
4.5. Yeah.
No, that's an 8. You cannot kiss.
Then 4 or 12. Another
Not
4 or
15, 15.
Yeah, 12 or 15, yeah.
12? Okay, open 12.
What are you at, 12 or 15? Yeah.
Let's go.
So therefore, the stroke is but one thing for sure, if the day and age, back in even our ESCC in Jaipur, anybody coming with a stroke in the ESCC, we are taking them to the lab, neuro lab. So key is that with a financial point of view, it's a good thing. I mean, from clinical point of view, good thing, but financial point of view, everywhere the stroke units lose money. We just to maintain around the round the clock. That's the reason. Because even they say that for STEMI, unless you do 7 to 8 STEMIs per month, you lose money.
Which of this is? To the LED?
Yeah.
Okay. Yeah, let me do the circ. Don't do anything. Good. Okay, now LED. $20. Okay, do it down.
I mean, the reason hospitals create a STEMI program
Okay, go up
is the
both.
halo effect of it.
That's it. That is it. That's exactly.
They start getting ACS and all sorts of
Okay, down.
That is absolutely correct.
Okay, get the IVUS ready.
Yep.
Do we need LED more? This is LED, right? It's not even going. Go up here. Don't go crazy.
No, this is the circ.
No. This LED. Yeah.
No, you change the thing.
Yeah.
Okay.
Yeah. Enough.
Samin, I do exactly like how I had mentioned at the beginning of the case. Probably the most teaching points in a single case, I think, have been for this case. Amazing.
Yeah, absolutely. Yes.
Okay, IVUS.
Okay, you want to take this picture and I go start my presentation?
Yeah, start your thing. I'm going to do imaging.
No, but you can take picture now so that we are done with this kissing. and then you just fix the
What I normally do is if everything looks good, I will take a final picture.
Okay.
So let's not do too many.
All right, let's go to why we're trying to just finish the IVUS and picture. So let's go to our presentation.
Okay, now, okay. I don't know. A wire came out.
I'll go to the slides, please. Okay.
Look at the imaging.
Yeah, so this is where we left. And now question is what I'm going to show. A lot we have already discussed. I'll just breeze through the few interventional trials from the TCT and AHA. Eclipse trial, imaging sub-study, Victory trial, which really will answer a lot of questions which we have along with the short cut trial and the Proctor trial. Then the different vascular injury by the interventional devices is the cadaver experiment done by Renu Virmani and the group to see vascular injury after various devices, which is IVL, cutting balloon or ultra high pressure balloon for calcium modification. So first one is the Eclipse trial. Remember the Eclipse trial was OA versus high pressure balloon dilatation, and overall showed, as you see on the top, no difference in that end point of 1 year at the TLF. But then they said, let's take the imaging out of it. And this was a sub-study published in JACC Intervention, presented in AHA. The OA and the BA on the right side, that IVUS guidance was done in about 2/3 of cases in the both groups. And within that, the majority was, again, 2/3 was the OCT, 1/3 was the IVUS. So intravascular imaging was done in 2/3 of patients. Of that 2/3, 2/3 was OCT, 1/3 was IVUS. And this is some of them are dedicated, still OCT sub-study, and the other one were just part of it. So they combined all of them, and particularly the OCT guidance. So overall, which you expect that by using an intravascular imaging, you'll use more catheter, more runs, and so on and so forth. But more importantly, that in terms of acute gain, that you did have a better acute gain after doing the imaging compared to angiographic guidance. As you can see, minimum lumen area and the final, there's no difference in perforation. But that's another point, and side branch treatment was in a small percent of cases. Crossover to other devices happen in 3-4% of cases only. So overall, imaging gave you better lumen, and the question was the TVF, target vessel failure, occurred in 13.2 in the angio group and 9.3. So clearly that from hazard ratio was 30% decrease in the event by using the imaging in these patients. As you can say, p-value 0.009. Now, okay, understood overall, angiography was inferior to imaging. Now, within the imaging group, let's go to the right side on top. The imaging OA and imaging imaging OA, imaging balloon angioplasty, imaging OA, angiographic OA and angiographic balloon angioplasty. So clearly that in each imaging group, once you do a OA and BA was not different, and at the bottom is IVUS versus OCT. IVUS has slightly higher event rate, but individual devices did not make a difference. So that basically message here is that imaging is better than non-angiographic guidance, and by using orbital atherectomy, by adding imaging, your event rate went down to the lowest about 8%. And these are the individual endpoints shown here. There was no difference in MI, but death, TVR, and the TVF and stent thrombosis all were lower. And this is basically put in the central illustration that event rate from 13.2 went down to 9.3%. So IVUS guidance imaging guidance was essential for the calcific lesion. Second was the Victory trial, and this was the trial of lithotripsy versus super high pressure balloon dilatation. So question was that a lot of places are using this special the open NC balloon, which goes up to 30 or 40 atmosphere and has shown quite safe, does not cause perforation. And idea was it for the prime time compared to cutting balloon where we go 16, 18 atmosphere. Here you can go 35, 40 atmosphere, and perforations have not been reported in the small trial. So this was the victory trial. Was the trial of lesion preparation with open NCB, non-compliant balloon versus IVL. So that was the concept. And the primary endpoint was basically the final stent expansion, and the clinical follow-up was 30 days, and will be going the 1 and 2 year data which at a later time. So overall, these are the cases with the moderate calcium in about 30%, severe calcium about 70%, and individual areas which is shown, vessel size, lesion length, and all kind of comparable between two of them, but more importantly here. So what we learned that by using open NC high pressure balloon compared to IVL, your final stent expansion was identical, 84 and 85%. Individual, the subgroup analysis showed the similar, no difference. So basically open NCB came as good as the IVL. Is ultra high pressure balloon dilatation of the open NC, which is a double layer balloon. You can go 35, 40 atmosphere, got you the same acute imaging outcomes. That's the key with the OC of the OCT type. Open NC at 85% stent expansion, IVL 84, other endpoints were not different. Whether they'll translate into an outcome at 1 year, we need to see. Then the third trial, which was presented in TCT, was the shortcut. Shortcut trial was really comparing IVL against cutting balloon in calcific lesion cases who have rotablation or no rotablation. So very nice trial design that patients who have planned rotational atherectomy or no planned rotational atherectomy, and each group had cutting balloon IVL, cutting balloon IVL. And these were the true calcific lesion, which they have tram track more than 5 millimeter, or 270-degree arc of calcium more than 5 millimeter, or 360-degree arc of calcium. So those are the clear-cut criteria of the imaging before the patients were randomized. So this is an imaging trial using intravesical lithotripsy versus cutting balloon. Cutting balloon went 3 times up to 16 to 20 atmosphere. And then, of course, we're using a high-definition IVUS. The individual endpoints, what they're supposed to answer is right here. And what did we find? Basically, the overall, this was again very calcific lesion. The balloon pressures were a little different. Arc of calcium was identical. Of course, with the IVL, you have a low pressure of 5.5 compared to 17 atmosphere with the cutting balloon. But the outcome point of view at the MSA at the site of maximum calcium was identical, 8.6 with the IVL, cutting balloon 8.0, so it was non-inferior for non-inferiority. And then overall, the various complications, secondary endpoints are shown here, which basically support that both were identical strategy in after the rotablation using IVL or the cutting balloon. And these are the where's the dissection perforations, and as you can see here, IVL has 0 perforation, cutting balloon have 0.5 perforation, event rate was only 1% with a strategy success of 90%. 30-day MACI was 2.9% in both. We have only 30-day endpoint. We do not have a 1 year or 2 year endpoint of the trial so far. Now, biggest thing was that by using, now you have good outcome, similar. But what are the price? About 3,600 more cost in the IVL group compared to cutting balloon. Why? Clearly, because the IVL cost around 4,000, cutting balloon cost about 850. So that was clear-cut difference which was seen. Now, the question was that what about at the places where there's the maximum calcium with the cutting balloon or IVL? So let's take only just cutting balloon and IVL again, exactly the same MSA. And atherectomy cohort, and then things are shown the same way. Now, what about in the non-atherectomy cohort? When there was non-atherectomy, then you see the IVL got the lumen of 8.8, cutting balloon got 7.7. They say it was not non-inferior. Basically means it was inferior. And the rest of the endpoints were not different, shown there. So clearly that MSA within the stent, you got a better lumen when you use IVL alone in a cases where you did not use atherectomy. So that's the only thing we learned. Anything else, complication, 30-day MACI were identical in both the groups. And of course, the procedural cost was lower in the cutting balloon group. So this is basically the central figure, and just to show the overall, what we learned from the trial is that cutting balloon angioplasty is a reasonable and less costly option when compared with the intravascular lithotripsy for the treatment of significantly calcific coronary lesion treated with imaging guided PCI, especially after rotational atherectomy. The last one was the trial called Proctor trial, which is a trial for vein graft. And basically showed that in the trial, we know there were guidelines 2A. You have a graft occlusion, you should try to go to the native vessel compared to the graft. But nobody has ever done the trial. And this was a trial, you have graft occluded. So rather than going to the, should you go to the graft or should you go to the native vessel? And this was the Proctor trial to answer that question, about 210 patients with a Mackie 1 year. Of course, the patients are a little different. Because of the more complex cases when the native vessel was intervened. But what was the outcome? Totally different than what everybody thought. Native vessel PCI has almost double the MACE rate compared to the vein graft intervention, with clearly lower MACE, mortality, MI, TVR, and TVF. So very, very surprised. A lot of people were concerned that how can it be? But basically, very diseased vein grafts are excluded. But otherwise, you have the vein graft versus you go to the entire totally occluded LAD, or you go to the vein graft supplying the LAD, you'll do a very good job by putting a stent in the vein graft with a very low complication that is shown in the central figure. So therefore, if the choice, I think they're going to change the guideline, which is 2A at present, that you go to native vessel. Idea is, if your vein graft can be approached, vein graft is better than the native vessel. The second point of the our general club type situation is differential vascular injury by various interventional devices using IVL, cutting balloon, or ultra high pressure balloon dilatation. And they basically, that you can see in the cadaver model, fractures which occur, and then you can see the medial injury also, but that you require micro CT and for excluding for various artifacts. So basically showed that once you have all three devices, IVL, cutting balloon, and ultra high pressure balloon, sizes were different, mean calcium score, calcium volume index was different, but to just say the depth of the fracture, that clearly, that as you can see here, depth of the fracture with the IVL, with the cutting balloon, and with the pressure high balloon, I think more ultra high pressure balloon and IVL came together, just like in our victory trial. Now, once you go to the medium, with or without fracture, the cases that you're basically the calcium occurred, when you have fracture or no fracture, all favored, I would say, the IVL. And the biggest thing which they wanted to prove is that the medial dissection. So these are the IVL, cutting balloon, and ultra pressure high balloon to see that what happens with the along with the fracture and medial dissection. So that is what we learned, that fractures are very common, more with IVL than any other device. Secondly, medial injury is minimal with IVL, 20%, compared to cutting balloon very high at 83 and ultra high pressure being 100%. Why? Because using a very high pressure. And then question comes is that IVL consistently cause fractures without injury, unlike cutting balloon and ultra high pressure balloon. Now, what does it mean? So we remember the data in the bare metal stent work. Once you do a bare metal stent, goes into the medial wall, we used to have high restenosis, and that is no longer happen with the current day and age. So whether it is going to show in the long term, we need to see. So let's come back to our endpoint of the recent interventional trial with the summary. Imaging versus angiographic guidance, PCI in heavily calcific lesion, 2 thumbs up. Open NCB versus IVL in heavily calcified lesion for stent expansion and cost, which our velocity trial, clearly the open NCB equally did good. Cutting balloon PTC alone or rota cut versus IVL alone or rota shock for stent expansion, both good. I put both of them, our open NCB and cutting balloon, because it was cheaper. And similar outcome. And SVG native vessel PCI post cabbage, I put a 3 thumbs up. Then there is a differential effect of lesion expansion by various interventional devices in heavily calcific lesion. Most important is occurrence of medial injury along with calcium fracture is noted, less with IVL versus ultra high pressure balloon or cutting balloon, and may be beneficial on long term but yet need to correlate with lower MACE and target vessel failure at follow-up. The three questions following are the true statement regarding the imaging guided versus angio-guided PCI in heavy calcific lesion Eclipse trial, lower MACE rate with IV imaging, lower TLR with imaging, lower ST rate with imaging, similar mortality between two groups, similar MI rates between two groups. Very interesting, the mortality was lower in the intravascular imaging group compared to angiographic group in the Eclipse trial. So clearly the D was wrong and so. Then in the Victory trial, what is wrong? Basically, similar primary efficacy, stent expansion, similar procedural complication, similar procedural success, similar TLF, and lower perforation IVL group versus open NCB. Answer is there was no lower perforation. They were identical, both of them IVL and open NCB. The last one with a shortcut trial, with or without IVL or cutting balloon, what is wrong? Similar complication between two groups, similar cost between two groups, similar stent expansion between two groups, similar procedural success between two groups, and cutting balloon PTC alone was not non-inferior to IVL alone for stent expansion. So answer wrong is B, because the cost was lower between the in the cutting balloon group and cutting balloon PTCA was not non-inferior. It was non-inferior to IVL because the lumen was almost 1 millimeter square lower with the cutting balloon when it used alone without the rotational atherectomy. So with that note, I'll conclude my presentation and let's conclude the excellent discussion and performance of the case. Anu, you want to show?
Let's go back to imaging, then I show the thing. If you see the IVUS there. Now I'm able to see all the comments also.
Yeah, actually, after a long tooth stent, there is a huge stent malapposition at the proximal edge of the left main. Also, in the mid LED stent, proximal edge has a malapposition. It's more than like 0.4. It's the most severe stent malapposition. Then Dr. Kinney did a post-irradiation again, specific on that malapposition part. Then no malapposition at the end. And the stent is well expanded. At the calcified nodule part, it's like area is like 14. It's well expanded. So entire stent is well expanded, no dissection, and finally no malapposition. It's an optimal result.
So going back to that question, right, where people were...
Ostial LED nodule.
Yeah, let's see.
How was it here? It's still there, right there, right there.
No, hold on. The first image, go back to the image here, angiography.
Yeah.
And see that, Kiski?
Yep.
What do you see in the imaging there? Everything else looks good for us.
Yeah, actually area-wise it's very good, well expanded, but there is a nodule behind the stent. That's why the stent shape is kind of like D-shape. That's why it looks angiographic and kind of like them. But the area is like 13. I think this is the best for this kind of massive calcified nodule.
Yeah, massive calcified nodule. Yeah. But do you understand the question about by doing IVL, look at the MSA. You're not going to get anything more. You're not going to be able to push that nodule anywhere.
Yeah. And your lumen is 3.42 millimeters, so you can 4.0 IVL will work here.
So other part is the other half is plaque free. If we do like super aggressive, it might cause injury behind the stent of the plaque free part. That's why we stopped.
Yeah. We're saying nodule is on one side, the rest of the three quadrants does not have anything. So doing anything further to take away that nodule will be more injurious. So this is a point where we say we accept it, MSA is good, and ready to conclude the case.
And because of the same region, that the two new IVL catheters are coming which are eccentric. So they will deliver the energy in that direction. So eccentric, not uniform like the current device. We do a circular acoustic or laser energy. But they are becoming eccentric IVLs, which will deliver, the dot, so you know which direction you are delivering the energy for the IVL modification.
Anu and Samin, so many comments complimenting this excellent case. As a final part, Samin, your presentation was great. Easily the thunder goes to imaging. Eclipse, Victory, and Shortcut. Sure. But to me, the real case here was the Proctor trial, which has totally changed the way we approach saphenous vein grafts.
Absolutely. And I can tell you, when we used to present the case, we have one or two cases when we presented the vein graft intervention, there were a lot of questions about it. Why didn't we go to the native vessel? We never did. We were always against. A lot of people were doing, and I get a patient's film sent to me with bad dissection. Said, can you fix it? I say, yeah, I'll fix it. It will take me 2 minutes. I put a stent in the vein graft and finished.
Fantastic.
Yeah.
Are they coming? Huh?
Yeah. Fantastic. Great work.
Anu,
No,
you
no.
are, yeah.
Showing something?
No, this is, yeah, let it play. No, this is how to engage, they were asking.
Yeah.
So this is the app, you can see that, how angiography, we say, once you have this kind of a self-expanding valve, see how the wire is going behind? Don't allow that, go with the J wire, so that you're in the center of the TAVR valve. And use the wire, you see that? But the newer generation valve, which will have a diamond shape as long as your commissural alignment is good, then you with the wire, you go into the diamond that you think is closer, then you see that you advance the catheter and engage. I mean, of course, this when you're coming out, like we're showing, be careful, use the wire and come out. That's what, otherwise you could see the displacement of the TAVR valve. It's not as easy as this animation is being shown, no matter what we use. So what we are very clearly saying is, when you have a self-expanding valve, the aorta, which is vascular, and it is pliable, right? With the metal cage that sits there, look at the primary curve and the secondary curve of the catheter, it becomes smaller. So you go with the smaller size. So if you were using VL35 or VL30, but certain catheters that are usually good both for left and right, what we have seen is Akari. So you can go with Akari 1, you can go to the left, to the right and do that. But more important is use a J wire. Use a J wire and go into that diamond. Be very cautious. Then you can show the SAPIEN.
No, SAPIEN
is much easier, but even then, better to go like we showed here, through the diamond. If not, you can go above the diamond depending on how the annulus valve, the valve was placed, all this. But this was the SAPIEN, it's a way easier. Any questions?
Anu, great teaching, excellent animation. We conclude this session, year 2025 also. We'll see you in the new year on January the 20th.